And good evening, everyone, and thank you so much for joining us for tonight's Woo You event with Dr. Susan Gramacki. Her talk will be on Introduction to Scleral Contact Lens Fitting and Practice. I'll be your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Metro Optics for exhibiting at this event tonight. They're going to have a special giveaway for their sponsor presentation after Dr. Gromacki's presentation, so please stay tuned for that. This will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. For your COPE certificate, if you could fill out that survey link that's in the chat now, and it'll also be there when the webinar ends. We will have a QR code at the end of this event, but you'll also get CE certificates delivered to you via email, and that will arrive within about 4 weeks. For questions, we will, if we have time to go over them at the end, we can ask them either in the Q&A section or in the chat there at the bottom. And then you can find that Q&A box at the top if you're on your phone, or the chat feature under the three dots under More. So please join me in welcoming Dr. Susan Gramacki. Dr. Gramacki is an internationally recognized expert in cornea and contact lenses with over 31 years of clinical experience. A graduate of University of Notre Dame and the Ohio State University College of Optometry, she completed a residency in hospital-based optometry with the U.S. Department of Veteran Affairs. She has authored nearly 850 lectures and publications, serving as a contributing editor for the leading optometric journals, and currently serves on the National Board of Examiners in Optometry. Dr. Gramacki is one of the only 24 optometrists worldwide to hold both a fellowship in Scleral Lens Education Society and diplomate status in cornea and contact lens refractive technologies from the AAO. She has received numerous honors, including the 2025 Contact Lens Institute Visionary Award and the 2024 Top Doctor Award from the National Keratoconus Foundation. So we're honored to have her with us today to share her expertise in all things scleral lens fitting. So here are her financial disclosures, all of which have been mitigated. I'll have you take it from
Thank
here.
you. Thank you so much, Dr. Sorenzi. And you've done such a great job as the host of these. I've really attended a few of them, and I've enjoyed all of them. And as you all know in the audience, Woo You is the best of the best. That's why you're here. It's certainly one of the best CE programs in our profession, and I'm absolutely thrilled to be part of it. So I want to thank Woo You for all of the hard work it's done in educating our profession. I want to thank them for inviting me, and most importantly tonight, I want to thank all of you for attending. So this is a basic course. So if you are an early adopter in scleral lenses like myself, take a good nap. I've got some kind of fun things at the end, but we're going to start really from the basics here. And I just want to say that scleral lenses have really made a profound impact on my patients and actually on my practice too. So I look forward to presenting some of the information I've learned over the last 15 or 16 years and help you maximize recruiting, fitting, and educating patients on these lenses. So I have built two scleral lens practices from scratch, one in an MD-OD group and another in an OD private practice. And I see probably about 10 scleral lens patients every day. So when I started fitting scleral lenses years ago, lectures like this didn't exist. I learned by trial and error and from the earliest adopters. So my goal today is to impart some of this knowledge and information to you. So how do you grow a scleral contact lens practice? First of all, you need the patients. We all need the patients. So we're going to be recruiting patients from many different places. Other providers certainly help me out in filling my books with these challenging scleral contact lens fits. So MDs for sure, including ophthalmologists, PCPs, even rheumatologists. Corneal specialists are probably number one in my practice, referring patients to me with corneal difficulties. Other ODs, I have a good group of ODs in my area that, for one reason or another, can't or really don't want to fit sclerals in their practice. So they serve as an excellent referral source to me. And how do you receive these? Well, certainly word of mouth is great, letters, emails, and or social media. And then lastly, many of these patients are right here in our very own practices. So who are they? In my practice, probably the most common patient has keratoconus or post-LASIK ectasia. Also, of course, keratoglobus, pellucid, which is sort of a cousin to keratoconus, as we all know, post-refractive surgery in general, RK, believe it or not, 20 or 30 years later, these patients really struggle. Post-corneal transplant, trauma or scarring, dry eye, corneal dystrophies and degenerations, high astigmatism, and lastly, we're fitting more and more for normal corneas. Normal corneas are the fastest growing segment in scleral lenses. These are patients that we used to fit in corneal GP lenses. Also, I have a good number of referrals that come in from ophthalmologists primarily to fit patients primarily to help their dry eye symptoms. This scleral lens can serve as almost a bandage, a scleral shell, to serve as a moisture chamber. And with that, we can't fill it with salt water. We have to fill it with non-preserved artificial tears to bathe the cornea in tears all day. That's really a big growing segment of my practice. Soft toric failures. You know, years ago we had patients -5, -6 SIL, and if they're in a soft toric lens, every time they blink, they're going to lose some acuity until that lens settles in. And the rotation aspect. Some of these high SILs, that lens is going to rotate and it's difficult. You're going to use LARS, but sometimes it's not consistent, and especially in a dry eye environment in older patients, scleral lenses work great in these types of patients. And next are against the rule corneas. If you remember from back in optometry school, that corneal GP on an against the rule cornea is going to align in the vertical meridian. Every time the patient blinks, that lens can move back and forth. The with the rule pattern where you're aligning sort of horizontally, it does come up nicely and centers nicely with the blink, but against the rule corneas can be pretty tough. So scleral lenses have been fantastic for them. Again, high corneal sill. One of the labs once told me that if you do make a corneal back toric or bitoric, anytime you're putting more than 6 diopters of sill on that, you will lose some optical quality. So switch to scleral lenses for better vision. And then there are many, many scleral multifocals in this day and age. I must say I do fit them. They're not perfect. Still, we have a lot of work to do on the technology there. But the difference is scleral lenses move less than corneal GPs. They provide better centration, and many of our lens designs are the success is predicated on good centration because they are not alternating, their simultaneous designs. So that lens needs to center up, and scleral lenses do tend to center up a little bit better. And lastly, athletes. I remember back in high school, I played high school basketball, and one of our players on our team, right in the middle of a game, her corneal GP popped out, and we had to stop the game, and everybody had to look for this contact lens. Now with sclerals, this would never happen because a scleral lens simply is not going to pop out. So the benefits of scleral lenses, they are many, and communicating them is very important, especially if you have a patient in your chair and you want to tell them the pluses and minuses of the different lens choices that they have. Sometimes they don't have a lot of lens choices. If they have a very severe case of keratoconus, scleral lenses are probably their best and frankly their only choice. But if you have a patient that you're trying to, say, switch out of a corneal GP into a scleral, you really need to use the right terminology to help that patient understand what's going on. So first of all, we talk about eye health. The scleral lens vaults the cornea, so protects it rather than scrapes it. You know, the research from Don Korb in 1982, Kleck in 2007 showed that flat-fitting contact lenses do end up with more scarring. Patients have more scarring than the steep fitting lenses. So we don't want to touch the cornea. Again, this is just for keratoconus patients only. Again, as I mentioned before, scleral lenses are excellent for dry eyes. So you can actually kill two birds with one stone. You can correct that irregular cornea and you can bathe that cornea in tears all day long. And unlike the corneal GP lenses, there is no 3 and 9 staining, which is wonderful because we are going to completely vault the cornea. And the comfort is certainly enhanced. We all know that versus a corneal GP. The reason is that even though it has a larger diameter, the edges tuck underneath the eyelids. So as a result, we don't feel them with the blink. And I actually do this to my page for my patients. This is the contact lens. These are your eyelids, and you're feeling the edge of that lens. It does take about 2 or 3 weeks to get completely used to it, but the scleral lens should feel very comfortable right upon first insertion. The other thing that happens is, of course, the contact lens is landing on the sclera, as we know technically the conjunctiva. What does that do? It gently embeds into the sclera. That gives us increased centration and increased stability as compared to a corneal GP lens, and most importantly, increased retention. Many of our patients in corneal GP lenses, especially as the keratoconus or the irregularity of the eye is advancing, they do lose a lens or two every year. And the elephant in the room, of course, is that scleral lenses are more expensive than corneal GPs. Well, if the patient's going to lose 1 or 2 lenses per year, now it's pretty much a wash. Scleral lens is probably more cost efficient. The other thing our corneal GP patients know very well about is anytime they get a foreign body underneath that contact lens, it feels like an ice pick. They have to take the lens out, rinse it, put it back in. With a scleral lens, it's really impossible for a foreign body to get under that contact lens. The other thing we used to do years ago, early in my career, especially for keratoconus patients, was we fit a piggyback modality. So a soft lens first with a GP on top to help with comfort and retention. We really don't need to do that anymore. Why don't we like to do that? Simply because of less oxygen getting to the cornea, because the oxygen has to pass not through one lens, but 2 lenses. Now we just have to fit 1 lens, and it makes it a lot simpler for the patient to clean 1 lens versus 2 different types of lenses. The other benefit would be improved vision. Why is the vision improved? Well, compared to a soft lens, it's improved simply because of the rigidity of the material. The other, sort of unsung hero of this lens cornea combination here is the lacrimal lens underneath. It literally fills in, I tell the patients, the nooks and crannies of your cornea, correcting those corneal irregularities, helping provide optical correction. And again, as I noticed, because that lens does gently embed into the conjunctiva slash sclera, it does have increased centration as compared to a corneal GP. And it also, of course, because of that, has less movement. So as I mentioned before, those high sil soft toric patients with fluctuating vision, you can really eliminate this complication with a scleral lens. The other sort of unsung hero is the optic zone size. If you think about a corneal GP, it's 9, 9.5, 9.8 millimeters. That's the entire diameter. Well, with the scleral lens being a diameter of 15, 16, 17, the optic zone is approximately the size of an entire corneal GP lens. So with that larger optic zone size, the main thing my patients notice is they can now drive again at night, because if you have a small corneal GP with a very small optic zone and it's decentering, they're going to really have issues driving at night. So this is a really, really big improvement. The other thing is, because that lens is vaulting the cornea, there's less corneal desiccation. So whether it's 3-9 staining, whether it's touching on that cone with the corneal GP, you'll eliminate that completely. And because you're not touching the cornea, this is another benefit, is there's actually less spectacle blur post lens removal. A lot of our other patients, even healthy eyes that were corneal GP multifocal, it's fit kind of in certain areas flat, certain areas steep, and they may have some corneal molding. With this, you really shouldn't have a whole lot. And then there have been studies that show that scleral lenses significantly reduce higher order aberrations than average, but others show that maybe it does induce some as well. But overall, it really does a great job with HOAs. And here's just one study for Formisano that kind of looked at all three modalities here, looking at glasses versus corneal GPs versus scleral in patients with keratoconus. And you can see glasses on average in this group gave vision of 2032, corneal GPs 2025, and scleral 2020. So I don't always expect a tremendous improvement in vision versus corneal GPs, but I do expect a little bit because of all the different options that I just outlined for you. So before you fit scleral lenses, this is critical. All of these tests must be new. They can't be taken from 3 months ago or 6 months ago, simply because, especially our regular cornea patients, keratoconus, post-refractive surgery, their cornea could be completely different than it was 3 or 6 months ago. So go ahead and start with a brand new refraction. Always look at slit lamp, look at things like scarring and SPK, document where it is. I want to see if fitting a scleral lens will resolve this SPK. Take an HVID. A lot of the fit guys have that sort of baked into it, as they need to know what the HVID is up front. Some of your topographers will take that for you, which is pretty nice. Either do a topography and or tomography. I like to get a lay of the land before I fit a scleral lens. Obviously, a lot of our corneal topographers are not elevation based. They are placido disc based, but they do at least give me an idea of where that cornea is flat and where it's steep. You can do an OCT if you want to. I personally don't, but this can be helpful. A corneal pachymetry or an endothelial cell count. I wish I was in an academic center and could do an endothelial cell count in private practice. The poor person's instrument is the corneal pachymeter. I do this on a lot of patients because I want to check for edema to make sure that, number one, it's healthy that they are wearing this lens, but number two, I want to make sure that they're not overwearing the lens. Everyone's different. I always recommend 12 hours a day or less with any contact lens, but especially scleral lens because it is pretty thick. And then depending on what they're coming in for, I may take a picture of their anterior segment to document scarring, to document other things that may be unique on that particular patient, but I don't do this for everybody. And then you may want to do a scleroprofilometry if you have that. One study showed that the number of lenses and follow-up visits at the moment is similar with and without it. And then the study by Yoon and Harthan and Skoog quoted, imaging technology does not negate the need for skilled clinical observation while fitting scleral lenses. So I think, the future is definitely going to be, we're going to want to know what's happening on the sclera. But at the moment, I think the technology just isn't quite there yet, but it will be in the future for sure. So the fitting process, very important for office flow. I don't know about you, but I have to go from one patient to the next, and I don't have a lot of time. So we do kind of work this into it such that we can be very efficient and we can have that lens settle on the eye, which is critical because that helps us with knowing how much that lens is going to be clearing. So very important for office flow, you want to master insertion removal. I actually put them in myself. I don't wait for a technician to do it because honestly, I can do it so much quicker and more efficiently. And then by the time I would get my technician, she may be with another patient, she may be on the phone. It's already in by the time I go to grab her. So I go ahead and do this. What you want to do is, if you can master it yourself, and I think you should if you're going to be fitting a lot of these, it really gives the patient a lot of confidence that they can do it. So they look at this lens, it looks extremely large to them, and you do it in about 2 seconds, and they can gain confidence this way. The other thing I do is, if you look on the bottom right, I dip the fluorescein strip right into the solution in the bowl of the lens. So this really expedites assessing the lens fit. Now, I will tell you, on follow-up visits, I do not remove the contact lens to put the fluorescein in. I actually paint the fluorescein below and above the edge of the lens, and I kind of push it underneath. I rotate the lens, and that's how I get it in. Because when they come back for a follow-up, I would love for them to come back for a follow-up at 8 o'clock at night so I can see how much that lens is settled, how tight it might be fitting. But obviously, we're not open then. We have them come in when it's convenient for them. So, but I don't want to break the suction of that contact lens. I at least want to get a feel for how it's fitting after it's been in the eye for a while. So your initial assessment, bottom left, is literally just with a handheld cobalt blue filter. I'm looking for a couple things. I'm looking for insertion bubbles, which number one, they're not healthy, they're not comfortable, but also patients may not be seeing very well for the overrefraction. And you want to check for a poor fit. So for example, bottom left, if it's touching the cornea, you want to remove that lens and put a different lens on there. Slightly steep is okay because the patient can still see through it. The overrefraction might be a little different, might be a little more minus, but if it's too flat, the pressure on the cornea can actually affect the overrefraction. So swap that lens out. So how do you choose the lens? I can't emphasize enough. Every brand is different, so follow the fitting guide for that particular lens. You follow the fit guide, choose the initial base curve or sag. Depending on the brand, you may have both. You may just have base curve, you may just have sag. And the goal, of course, if you look at the picture on the right, is a sagittal depth greater than the sagittal height of the eye. The lens should land gently on the sclera without any corneal or limbal contact. So one rule of thumb, and every lab is different. So look at the fit guide, but you want a diameter at least 2 millimeters larger than the corneal diameter. So for example, if the HVID is 11.8, you start with about a 15.8. The elevation, you can either use a topographical elevation map, anterior segment OCT, HVID. One fit guy says literally look at the side profile of the patient and guess it from there. Um, you can guesstimate based on, the size of the cone, the steepness of the cone, or simply by judging the severity of the condition, again, just based on the patient's visual acuity, based on topography, a lot of different things. So in general, though, the more corneal irregularity, the larger the lens diameter is. So for our healthy patients who may just, need this type of lens in lieu of a soft toric, they may be in a 15.0 diameter to 14.8 diameter. But your, very severe keratoconus patients are probably going to be in at least a 17.0 diameter. So the fitting process, again, this is very important. Lenses settle. They settle over the course of the day, weeks, and even perhaps 3 months after the initial fit. The conjunctiva and the sclera are quite spongy, and everybody's is different. Some say that older patients have sort of a less spongy conj than the younger patients, but there's certainly a bell curve and everybody's different. But one thing we do know is that lenses settle. So we give ourselves much more diagnostic information by letting that lens settle 30 minutes in office. So put the lenses on, have the patient sit in the waiting area. I always educate them that this is just my trial set. It's not their exact prescription. We'll determine that in a little bit. And then I see my next patient. Maybe I see one more patient. Then while the lens is settling, I have my technician do an auto-refraction over the contact lenses. Then when the 30 minutes is up, then I bring the patient back, dial them into the proctor, and determine what the prescription is. So as you can see from these studies, a lot of them say that 63 microns and 80% is in the first 4 hours, 88 to 134 microns within 8 hours. The highest rate, again, is that first 30 minutes. And then here's another one, 83 microns in about 6 to 8 hours. Now, this is very important. This Bray study, I have the bullet point. There's no change in overrefraction during this time, which is very interesting. So, my technician can grab the patient. I like it to be in there at least 10 or 15 minutes, and then she can do the auto refraction. I'm not waiting exactly 30 minutes for her auto refraction, but I am waiting 30 minutes for any settling that might happen. And I'm confident that the auto refraction, based on the study, will still be pretty good. So then you want to view the entire lens, center, limbus, and sclera. So limbal clearance, cobalt blue filter to do an overall scan of the cornea, looking for areas of touch. So you can see this particular patient, it is touching over the limbus, touch meaning sort of a blue or darker color, whereas the clearance, of course, is the green fluorescein. So you should see fluorescein across the entire cornea, including the limbus. Bottom right, you can see it with white light. If that green is sort of passing the limbus onto the conj, that's a good thing. That means that certainly it's vaulting the limbus. And the limbus is pretty important because of the importance of the limbal stem cells to the health of the cornea. We don't want to be pressing on them. We also don't want to be vaulting too much because we don't want a hypoxic situation either with those limbal stem cells. We want a nice light green overall picture. But I will say that studies have shown that it is difficult to see fluorescein at less than 40 microns. So sometimes if you're kind of in doubt, bring it down to the optic section, white light, scan across the cornea. If you're getting more than 1 millimeter, it's probably touching at the limbus if you really have a hard time seeing it. Because if you touch the limbus, it can certainly cause SPK there, and that's not a good thing. And like I said, hypoxia also if it's too much clearance. So eliminating the limbal touch. Now we'll get into a little bit of fitting here. A couple different ways. As you can see in the picture, the one on the left, 14.3 millimeter diameter. So that's a very small diameter. And as you can see, very limited limbal clearance. You really have to pass that beam in past the 1 millimeter to see any green at all. So that is certainly touching at that limbus. And this is in even blue, the cobalt blue. This is simply your optic section. And just by increasing that diameter to 14.6, only, 0.3, as you can see, bringing that slit lamp beam in, it's going to show the green clearance 1 millimeter or less. It looks like it's probably about 1 millimeter. So I think you're in the clear. You're clearing the limbus, and that was a really good thing. Now, there's a custom feature on pretty much all of our, commercially available lenses now where you can just increase the limbal clearance just in that spot. Some it's 360, and there's other companies that you can do it, in quarters or even a little better than that. So you can choose what you want to do. The other thing you could do with some brands on their fit guide, it says that if you steepen the base curve, then you increase the sagittal depth of the entire lens, including the limbus. But keep in mind, if you steepen the base curve or increase the sag, you're also affecting central clearance. So sometimes if I'm looking at the central clearance and it's perfect per that manufacturer, the only thing that's happening is the limbal touch. I'll either increase overall diameter or I'll just have them increase the clearance over the limbus. That way I'll leave my central clearance alone because I'm happy with it. So then I go down to a white light optic section. So if you have any areas that you're questioning that it might be touching, for example, at the limbus, for example, in a PKP at the graft host junction where it's sometimes kind of irregular, that's an area that I'm always looking at with great care and caution that I'm not touching because, yeah, that would not be a healthy thing. You certainly don't want to cause any rejection in that transplant. And then, of course, over a cone. Narrow it down to white light optic section and look for that little tiny band of green clearance. All that matters really is that it's clearing. Sometimes with extremely irregular corneas, you might have 350 microns clearance centrally and 75 over the cone, and that is just fine. But be careful with that 75. If it's right when the patient puts their lens in, that 75 will probably be 0 at the end of the day. So again, make sure you're assessing it after at least 30 minutes. And then for those of you who are really new at this, here is a great picture. The Michigan College of Optometry came up with these pictures a few years ago, and they're just so great for learning. The other great way to learn, obviously, would be to put the patient on an OCT, and that would tell you exactly how much clearance you have. But I will tell you, if you don't have an OCT for this, you really need to know the lens center thickness from your lab. Make sure that the trial lenses have the center thickness on there, because that's how you determine the width of how much it's clearing, is comparing it to the center thickness. Because honestly, the cornea could be a whole lot of different thicknesses. You may have done a CCT, but you may be looking at a point that's a little bit thinner or a little bit thicker, depending on what the patient's diagnosis is. So going from left to right, you have a tear layer, a little bit of green. Then that sort of darker area is the lens itself. In this case, it's 350 microns. And then you have the clearance. And in this case, it's pretty much equal to the width of the lens center thickness. So it's 350 microns. And then you have your corneal thickness, which is probably about 550 in this case. Again, follow your fit guide. Central clearance values, depending on the lens brand, vary anywhere, recommended from 100 to 400 microns. 400 seems like a little high, and again, 100 seems like a little low. So I usually aim for between 200 and 300. I like to give the patient a little extra wiggle room. I mean, ideally, we would love it to be about 50, but you know that at some point in the day that will be touching the cornea. So you really have to balance out how much it's clearing. Um, because we don't want hypoxia. This is a thicker contact lens than a corneal GP. It's about 3 times as thick. And the oxygen has to pass through not just the plastic, but also the lacrimal lens. So we don't want it to be too thick. Also, if it's too thick, it could knock down vision a little bit. Probably not a lot, but a little bit. So we do want to keep it minimal, but not so minimal that A, it'll touch at the end of the day, or B, you got to give some wiggle room because these corneas can change. These post-RK, post-LASIK, keratoconus, grafts, they do change. And the last thing the patient wants if they're paying out of pocket is to have to purchase another lens in 6 months, because they are pretty expensive for the patient. So experience matters. This was a couple of interesting studies. The first one was performed by my friend Dan Fuller at SCO, and he had some fourth year OD students judge how much a lens was clearing. And this was pretty interesting. The fourth year students tended to overestimate the central clearance, particularly as the amount of clearance diminishes. So if the OCT on average showed that the central clearances were 341, the mean guess by the OD students was 398, with a range from 315 to 362. Now, when the OCT showed the central clearance to be 105, they guessed on average 220 microns with a range of 50 to 480. So definitely it helps to have some experience here. Here's a more recent study just recently published, that showed that scleral lens fitting proficiency is achieved after 26 fittings and even more for regular corneas. So practice does make perfect. After a few, you will notice that you're getting better and better, and you probably don't need the OCT anymore to judge clearance. And then here's again the take-home message from this MCO aid here. It really does help you initially figure out how much clearance you have. And then literally the more and more you do, you really won't need this anymore. But when I am writing down how a scleral lens is fitting, every single patient, I make a note how much central clearance, what it's doing at the limbus, and then what it's doing at the edge. And we'll talk about the edge in a minute. And then, of course, if there's anything unique. So as I mentioned before, I might say central clearance 300 microns, clearance over the cone 100 microns, because it will be different. So that's the sort of thing that I mentioned, just so I can compare one visit to the next. All right, then a white light parallelepiped looking at the conjunctiva slash sclera. You want to look 360 degrees. You don't want the patient to look down because that will affect how the edge is sitting, or look up. You want to pull down the lower eyelid, pull up the upper eyelid, and look all around. What you're going to be looking for is alignment. This picture here on the left, you can see this white strip here. This is impingement. This is not good. That means it's too tight or too steep. This patient down below, lower right, patient of mine, really crazy. I kept And this was a regular cornea patient, not a keratoconus patient, just a very high cylinder patient. I think she had about 7 diopters of cyl, if I'm not mistaken. And I just kept trying this upper edge to fit, and it just kept doing this. And I didn't trust that I needed to change it more than I did. But definitely look for something like this. This is an aberration. I don't see a lot of these lifting off like she did, but she certainly did. Okay, then once you look at your fit, or perhaps even before you look at your fit, you need to do an overfraction because obviously the trial lens is not the patient's prescription. I do a spherical first, and if I gain the acuity that I'm expecting, then I'm done. If I'm not, then I will dial in the cylinder. So I have my auto refraction printout that my tech did. Usually what I'll do is I'll keep it by my side. I'll take the sill out and I'll get it with the sphere the best I can. If it's not really doing very well, I go back to my little piece of paper. I dial the sill back in at that axis and I do a spherocylindrical overfraction. Now sometimes you could get some sill if the lens is flexing. So if you're in doubt whether the lens is flexing, just do an over K or an over topo, and it should be spherical because it's a spherical trial contact lens. If it is flexing, there are things you can do in the order to help out. One would be a thicker center thickness, which again, you have to be very careful of because of hypoxia. But also, you could use a toric peripheral curve, which we're using more and more and more these days because we do know that the sclera is asymmetric. If it's not flexing and you're pretty confident that the patient does have some internal sill, and many of them do, order an anterior toric. And then don't forget, obviously, with your overfraction, to vertex it back. So in your lens order, you're going to specify base curve, sag, limbal curves, peripheral curves, diameter, and then anything special, for example, a ball over the pinguecula. Every lab is different. They make it very easy for us to do the calculations. I really like that. I can zip it out in just literally 5 minutes, is do some quick math. Some have calculators online. You just go in, you plug and chug what the trial lens is, the overfraction, what you want to change, and then others you have to call consultants. And some you really do need the lab consultants after a while. Now, center thickness, you don't always have to specify this because it generally just comes with all the other parameters that it sort of self-calculates itself. But if you really do want to specify it, go ahead and do that. Sometimes the lab will tell you, though, that they can't make it as thin as you want it to. Material, I use as high a DK as I can. With sclerals, I go over 100 for sure. There's more silicone. Typically, the higher you go in the DK, it's softer and more prone to scratching. You can put the tangible hydropeg coating on there to prevent that from happening. I mentioned center thickness. Again, looking at the different labs and designs, they recommend anywhere from +2 to 0.2 to 0.5 millimeters. It's usually about a 0.3 or more. Again, you got to be very cognizant of it being too thick. That can cause hypoxia. If it's too thin, that can cause warpage of the contact lens, which affects vision, and it can cause it to break a little bit more readily. Your patients are not going to be happy. I do limit it to 12 hours a day, no extended wear. And we ask every single time how many hours a day the patient is wearing their lens. There has been some good research here on how thick a scleral lens should be. Probably the hallmark paper is by Langy Michaud out of Canada. And he actually wrote that most scleral lenses do not provide sufficient oxygen to the cornea based on Holden and Mertes criteria. But other papers have disagreed. But in general, I think most people agree that scleral GP lenses should be fitted with high DK materials and without excessive clearance. So this is very important. Discontinuing from handling difficulties is more common than from vision or discomfort. Like I said, most patients should be very comfortable with these lenses the second you put them in with the trial lens fit. Now, they will say that they feel there's something in there. That's normal, but they shouldn't be painful. And sometimes your corneal GPs are. So really have some great education for your staff, whether you have one dedicated technician, two, or whether you do it yourself, because this can make or break success with contact lenses. I've written a ton on this in different journals. You can just Google me and you can see everything that I had come up with over the years when I was an editor of Contact Lens Spectrum, and sclerals were just increasing in popularity. So it was really, my pleasure and privilege to help contribute to the literature. So there were a lot of things that I learned along the way. Here's some handling ideas. They can use the tripod method, but it does get a little bit, unbalanced, certainly a little wobbly there. So they can use a large suction cup. This is what we recommend in my practice. We actually cut off the very bottom of the suction cup because we don't want any suction. And then, of course, lots of other great tools here to use. The sea green lens inserter, again, this has been a savior for some of my patients who have a hard time opening. And this is probably the standard of care. There's a lot of them you can get now online. Patients are making their own. There's this little one that's the newest one out there. I will tell you though, the base, the little arms, we had one in clinic and it broke after about 3 or 4 patients. So it is less expensive than the sea green, but the sea green is less expensive than some others. There are a lot of choices to help the patients. The one thing I notice is they really have a hard time initially keeping their head down, especially if they're a soft lens wearer. They like to keep their head up when they kind of look their lens in the mirror into their eye. I sometimes have to very gently kind of push their forehead down the very first time to get that lens in. And then bubbles can be a problem initially, about 2 to 3 weeks into the INR. They could get some air bubbles, and that's from a couple things. Their head's not parallel to the ground, they're not filling the lens to the rim, and they're just not adept at it. So some of the solution is spilling out. You can use Refresh Celluvisc or another viscous artificial tear, just 2 to 3 drops. You don't want to fill the whole thing with it. It can knock down vision, but the viscosity does help some of the solution from spilling out when they're trying to insert it. Removal, you can use the above and below method. You can use a little DMV, a little suction cup. You want to have them place it about 6 o'clock, pull up and out. I like to have them put a drop of saline or artificial tears onto it. It just helps with the adhesion. You can also have them look up, pull down their lower eyelid, introduce air bubbles on purpose. It breaks the suction, helps it come out a lot easier. Filling the lens, this is what we had initially, right? When I started out, we only had this 0.9% sodium chloride solution. Obviously, the Adipac brand is the most popular. It is not FDA approved, but it is the least expensive. A lot of patients like me to write a prescription for it because their insurance will cover it, so it's pretty nice. But it is still considered off-label. These are FDA approved. These are also just salt water. They're saline, lacquer pure, sclerophyll, vibrant view. They're all a little bit different. Tangible fill is the newest one. It's also still 0.9% sodium chloride. Just came out in October of last year. Okay, you're gonna, get me on my soapbox here. My good colleague Gloria Chu did a study published as a poster at the GSLS meeting because these large bottles, not preserved, they will start to grow pathogens. There's no way around it. Yet, when somebody Googles scleral lenses, the search engine puts Pure Lens Plus right up there, a 4-ounce bottle. For some reason, they got FDA approved for this. This Pure Lens was never made for scleral lenses. It was invented to use with actually a little system called Pure Lens, which plugged into the wall. It was a UV disinfection for soft lenses. If patients are using this, I immediately switch them over to an individual vial because, as Dr. Chu found, she took 35 patients, 63% of their bottles were contaminated with 21 different microorganisms. It's just not a safe way to do it. The other option would be unit dose artificial tears. I mentioned this for the dry eye patient. This is so helpful. Be very careful which brand you use. Some have gelling agents in them, but it's the kind that are clear. Sometimes they switch to a more opaque one. That one's going to knock down vision. But this really helps also for patients like keratoconus patients who may have an area of very minimal clearance. It does give a little bit of space between there, a little cushion, so that lens is less likely to touch the cornea. Neutrophil is also excellent, but as you probably know, at the moment it's unavailable. On just May 15th, just last week, there was a voluntary recall with 6 lots, and the products may not be sterile. So obviously, this is a great solution, but Contumac is looking for a different partner so that this hopefully will not happen again. I have patients who've switched to this. They swear by it. They'll never go back to salt water. Okay, so scleral lenses need to stay clean. These patients, most of them have irregular corneas, they have decreased vision, they get a daily cleaner, they rinse it with saline, and they disinfect with most of them with a gas permeable conditioning or disinfection solution. Sensitive eyes people do need to rinse that off with saline in the morning. Any saline is fine, even a big bottle of saline. They can use Clear Care because it's not preserved. It's a great disinfectant, as we all know, but not all scleral lenses fit in the Clear Care basket. About 16.6 millimeters max, and also be careful of what the sag is as well. They can purchase a bigger case from Dry Eye Zone. That is made specifically for scleral lenses. However, it doesn't have the disc with it. So they also have to buy Clear Care. Generally, the disc, the case will come right in with it. They have to pry the disc off the Clear Care case, put it in the Dry Eye Zone case. Note that this is the only one that is approved without a digital rub. Okay, everything else, every other multi-purpose solution needs a digital rub. But the original Clear Care, this is a little bit unwieldy for some patients, needs a digital rub per the FDA. The Clear Care Plus doesn't. Clear Care, rub it with something, whether it's saline, whether it's some Clear Care, but be careful because if they're touching their eye, that would be not good to introduce some hydrogen peroxide into their eye. But just keep this in mind. Clear Care is a really great option, but they can either scratch or crack the front of the lens if they're not careful closing the basket. US FDA says don't use tap water. I agree with that with scleral lenses. Corneal GPs, I'm a little more lenient because they're moving around. Scleral lenses, if there's anything in that tap water, and there is, it'll be trapped up against the eye all day. So be very careful. Don't use tap water with scleral lenses. Lots of information. Like I said, I've written a great deal. I've published a great deal. I've given webinars on this. There's entire webinars if you Google it with the National Keratoconus Foundation, GPLI, and you can hear entire lectures that I've given just on cleaning and caring for scleral lenses. Troubleshooting. Why is it more frequent that that lens comes back, not wetting? Well, one of the labs told me that with sclerals, it's a larger diameter lens, so the diamond lathe makes contact with a lens blank for a greater amount of time, thus creating additional heat and resulting in non-wetting. And this is present whether it's plasma treated or not. But however, it would not be present with tangible HydroPEG coating. So once that coating is put on there, that's a good thing. Makeup contamination. Here's a patient of mine. You can see the marks from the mascara wand. And why are you touching the scleral lens with the mascara wand? Because they're thicker. They're used to doing this, and now that lens is protruding out and it's touching. And this is not always easily removed with over-the-counter daily cleaners. So how do you eliminate the deposits? You can take your little DMV and kind of squeegee it on there with some multi-purpose solution. A Q-tip might be a little too harsh sometimes, but as long as it's wet enough, you should be okay. But I prefer the DMV. If it's not HydroPEG coated, you can use Boston Lab Cleaner. You can use Progent by Menicon. Keep in mind, though, the active ingredient in that is bleach. So you have to make sure that it's rinsed off completely. If you have a polishing unit like I do, you can certainly polish it. But all of these things will negate the effect of either plasma treatment or the tangible HydroPEG. Simply, you can order a new contact lens for the patient. Tangible HydroPEG is great for reducing deposits, is warranted for a year, and it does, however, rub off because it is very soft. Okay, this is something we still have not solved, the midday fogging. but we do know a little more than we used to. Maria Walker has done some great work in this area. We know that a good number of scleral lens patients have it. It can decrease vision, but not always comfort. Precise cause is unknown. Lipids, several classes and species, NHLs, immune cells, leukocytes. It's not mucins. We do know that, and we do see this much more common in patients with dry eye. We used to say we saw it a lot more common in patients with larger scleral lenses because you're landing on more of the sclera, although I'm not sure if that has really been proven. So cause and solutions would be excessive central vault. So to reduce this, you want to either flatten the base curve, decrease diameter, or order an oblate shaped lens. Could have a flat edge, giving it a path for this debris. With that, you want to do a steeper or a toric PC, or as like I said before, add refresh celluvis to the lens bowl. It could be moving excessively. Movement isn't a horrible thing for a scleral lens unless you've got this type of situation, or if the patient's uncomfortable with the blink, because sometimes they'll feel it. So you want to optimize the alignment of the landing zone. As one study showed, Jenny Fote, one of our Academy diplomates in the cornea contact lens section, complete elimination may not be possible. What the patient may have to do is remove the lenses midday, rinse, and refill them. When to use toric PCs? Definitely if the lens is decentering, it helps to align with that sclera a lot better. If there's asymmetric blanching, lens flexure, debris, discomfort, and certainly as you go, as you probably know, further and further into that sclera, the larger diameter lenses are going to need it more than the smaller because the sclera tends to be more toric or asymmetric as you get further out. IOP, this is something that's been controversial. Do scleral lenses raise IOP? Here's a study by Macedo that said that they do not. All right, I can't wait to share this with you because this is fun. I've been doing this for a long, long time with scleral lenses, and my patients are very smart. They have come up with some really great things that have helped their scleral lens experience. So let me show you some of them. Okay, this first one actually was invented by my technician. She took an old clear care case, takes the basket out, and it becomes a really great carrying case for your DMVs. Now, I will tell you, I don't want this to be wet and to be locked in all day and all night. This is purely to carry them around because these little tools can also start to grow pathogens. So patients ask me all the time, how do I disinfect my DMVs? Well, you can use rubbing alcohol, you can use hydrogen peroxide, but make sure you rinse them profusely with saline afterwards and air dry. But this is a great little way to put them in there, and then you do not want these devices just thrown into a purse, thrown into a pants pocket. That's not a sterile environment. As long as these are dry, this is a great way to carry them around. Here's the pill box, AM and PM. This is awesome. Here's the plastic tube. This is a really interesting idea, is instead of purchasing, a fancy device, and some of these insertion devices are $399, 400 and something dollars. That seems like a lot of money to me. It's going to seem like a lot of money. So they got this little lighted makeup mirror, and it almost served as a cheap version of the sea green device. The tea light works wonders. Look at this. Tea light, put your DMV on there. Look at that. You've got a homemade sea green device. Dollar store tech holder. Check this out. Look at that. Perfect for a couple of vials of saline, the DMV, and your case. The makeup mirror. Really great idea. The garden hose. Because I tell my patients, you can reuse this throughout the day, but I would throw it away at night because you don't want it to grow stuff, right? We're talking about the non-preserved saline. And I also tell them, because it's non-preserved, if the tip touches anything, you must discard it. So this patient cut up his garden hose. It's not touching the tip. And there he has his own little way of making sure the tip isn't touching anything. The bento box, that made for a very nice carrying case. Okay, let's talk about a quick case here. So I'm going to leave you with an image from an actual patient of mine. This could also be considered best commercial for a scleral lens. So during an overrefraction, I was overrefracting a GP patient, and all of a sudden he said, my vision went blurry. And then every possibility crossed my mind. Why is his vision blurry? Until I looked at this. Look at that. His lens had popped out right into the phoropter, literally right into the phoropter. Well, needless to say, this patient was very easily convinced into switching into a scleral lens. So the future is bright for scleral lenses, no doubt about it. Scleral lenses are making a big impact on our patients' lives. They've become a very important part of my practice, and I wish you the best in making them an important part of your practice as well. So thank you again to Wu Yu, to Dr. Serenze, to everybody involved. The team behind this was amazing. I really thank everybody. I thank you all for coming, and I hope you have a wonderful